we were on carpal tunnel syndrome during pregnancy due to fluid retention. Their median nerve can be compressed in the carpal tunnel, which can lead to carpal tunnel syndrome. Anal test, which is usually used to diagnose carpal tunnel syndrome, is that tapping the median nerve will result in the numbness of the area that is supplied in the by the median nerve. But tinnial test is not always positive. It has a very low sensitivity. So a pregnant female presents to you with numbness in the thumb, index, and middle finger, numbness or tingling sensation or paresthesia or pain in the territory of median nerve, then the diagnosis is most likely carpal tunnel syndrome, and it is managed by cutting the transverse carpal ligament to relieve the pressure on the median nerve. Transverse carpal ligament is also called flexor retinoculum or anterior annular ligament. The next topic is anal fissure. So the presentation of hemorrhoids is bleeding per rectum, bleeding per rectum without any pain or mild pain. A patient with a history of constipation, if he or she presents to you with bleeding per rectum or bleeding or splashing of bright red blood during defecation with mild pain or no pain, then it is hemorrhoids. But if the main complaint of the patient is pain on defecation or extreme pain on defecation, the pain is such extreme that the patient will refuse a rectal examination. And in anal fissure, there will be blood streaks on the stools, while in hemorrhoids, there will be splashing of bloods, or there will be large amount of bright red or fresh blood, not streaks on the stools. So if the main complaint of the patient is bleeding per rectum while defecation, then it is hemorrhoids. And if the main complaint is pain while defecation, then it is anal fissure. Constipation and straining both are risk factors for hemorrhoids and anal fissure. In hemorrhoids, there is painless rectal bleed. In perianal abscess, there is throbbing pain, swelling as well in an area around the anus, and there is usually no blood. And in perianal abscess, patient can also complain of fever. What is the management of anal fissure? The management is very simple. First one is that you will advise the patient dietary advice such as high fiber diet with high fluid intake. You will also prescribe bulk forming laxatives, and if bulk forming laxatives are not tolerated, then lactulose can be tried. And before defecation, petroleum jelly can be tried as a lubricant. Topical anesthetics can be used, or analgesia can be used for the severe pain during defecation. This is the management for acute anal fissures. What are acute anal fissures? Acute anal fissure, the duration of acute anal fissure is less than 6 weeks. Dietary advice, bulk forming laxatives, and if not tolerated, then lactulose, petroleum jelly as a lubricant, topical anesthetics, or analgesia. What is the management of chronic anal fissure? The management of chronic anal fissure is same. you only need to include one more drug in the management of chronic anal fissure, and that is topical glyceryl trinitrate. Topical glyceryl trinitrate will relax the anal sphincters, and the patient will not feel any pain during defecation. But if topical glyceryl trinitrate is not effective after 8 weeks, then he need to be referred to a secondary care clinic for surgery. The surgical treatment for anal fissure is sphincterotomy. A cut is given in the sphincters, or if surgery cannot be performed, then botulinum toxin injection can also be given, which will relax the anal sphincter. So this was all about anal fissure. Extreme pain on defecation. Management include dietary modification, bulk forming laxatives and lactulose, petroleum jelly, topical anesthetics, and analgesia. And if the duration of symptoms is more than 6 weeks, then glyceryl trinitrate topical. If no improvement with glyceryl trinitrate after 8 weeks, then refer to secondary care for surgery or botulinum toxin. Next topic is hernias, inguinal hernia, femoral hernia. Inguinal hernia is usually above and medial to the pubic tubercle, and femoral hernia are below and lateral to the pubic tubercle. This is a general assumption. Inguinal hernia can be direct inguinal hernia or it can be indirect inguinal hernia. Remember that inguinal hernia impulse on cuff and they are reducible. This is an important differentiating point for Plab1 exam. More important than this one, above and medial to the pubic tubercle are inguinal hernia, and below and lateral to the pubic tubercle are femoral hernia. Inguinal hernia are reducible and they impulse on cuff, while femoral hernia they rarely impulse on cuff, plus they are irreducible because the femoral canal is very narrow. Femoral hernias are common in females, F for femoral and F for females. Inguinal hernia is common on male. Because they are not easily reducible, so they can strangulate, and they are irreducible. While on the other hand, inguinal hernia are reducible, so that's why the management is also for both the hernia is different. In inguinal hernia, if the patient is asymptomatic, then we can manage the hernia conservatively. No surgery is required in inguinal hernia if the patient is asymptomatic. While in case of femoral hernia, even if the patient is asymptomatic, we need to perform surgery. The only option in case of femoral hernia is surgery. While on the other hand, inguinal hernia, asymptomatic inguinal hernia are managed conservatively, especially in elderly patients. So if the hernia is strangulated or incarcinated, strangulated means if they are not reducible or they stuck in the opening, then the blood supply to the hernia or the content of the hernia will be compromised and it will result in strangulation and it will cause extreme pain, and also the patient can complain of vomiting. So if this is the case, then urgent surgery is required for the management of strangulated or incarcinated hernias. Inguinal hernia are more common in males, so risk factors for inguinal hernia is ill sex, lifting heavy objects, old age, chronic cough, anything that can lead to the weakness of the abdominal wall or an increase in the abdominal pressure can lead to hernia, such as lifting heavy objects, old age. In old age, the abdominal wall is weak or lax. Chronic cough can also lead to weakening of the abdominal muscles, and previous abdominal surgery can also lead to weakness in the abdominal wall. Now, inguinal hernia can be divided into two categories: indirect inguinal hernia and direct inguinal hernia. Indirect inguinal hernia, let me show you a diagram. Now, this is inguinal ligament. This is inguinal canal. This is deep inguinal ring, and this is superficial inguinal ring. Indirect inguinal hernia, they passes through deep inguinal ring, then they enter in the inguinal canal, then they passes through superficial inguinal ring, and then they go into the scrotum. While direct inguinal hernia, so from this diagram, this one is a this triangle that you can see is called Hasselbeck's triangle. Here are lying the on the roof of the Hasselbeck triangle or the lateral boundary of Hasselbeck triangle, there are inferior epigastric artery and vein. So from this diagram, you can tell that indirect inguinal hernia is lateral to the inferior epigastric vessels because it passes through the deep inguinal ring and then through superficial inguinal ring. So indirect inguinal hernia are lateral to the inferior epigastric vessels, or inferior epigastric vessels are medial to the indirect inguinal hernia. While direct inguinal hernia comes out directly from the abdominal wall in this place. So inferior epigastric vessels are lateral to the direct inguinal hernia, or direct inguinal hernia is medial to the inferior epigastric vessels. Both the statements are correct. Indirect inguinal hernia passes through the deep and superficial inguinal ring and lies lateral to the inferior epigastric artery. Indirect inguinal hernia is lateral to the epigastric vessels. Or what is the other way to describe it? Indirect inguinal hernia or epigastric vessels are medial to indirect inguinal hernia. Let me show you the diagram again. Indirect inguinal hernia is lateral to the inferior epigastric vessels. Direct inguinal hernia passes through the posterior wall of the inguinal canal directly and lies medial to the inferior epigastric artery. Indirect inguinal hernia are common in young children or young adults because of a patent or persistent process vaginalis. Children or young adults can develop indirect inguinal hernia. And as direct inguinal hernia, they passes directly through the wall of the inguinal canal. That's why they are more common in adults adults with a history of cough or weightlifting, or old males, they can develop direct inguinal hernia because their abdominal walls are weak. Is it clear up to this point? Is there any question anyone want to ask? Okay, our next topic is paralytic ileus. Paralytic ileus means no GIT motility or non-functioning bowel or no peristalsis in the GI tract. It is one of the complication or post-operative complication of abdominal surgeries, because during abdominal surgeries, manipulation of bowel loops can lead to paralytic ileus. Causes that are other than surgery that can cause paralytic ileus include electrolyte imbalance such as hypokalemia or hypercalcemia. Both of them can cause paralytic ileus. Anticholinergic drugs can also cause paralytic ileus because they will inhibit the peristalsis. After trauma, paralytic ileus can also occur, and opioids can also cause paralytic ileus. Peritonitis can also cause paralytic ileus. Immobilization can also cause paralytic ileus. So the causes that you need to remember include postoperative complication. If a person develops constipation and abdominal distension after an abdominal surgery, and on examination the bowel sounds are absent, then it is most likely paralytic ileus. So paralytic ileus can develop after surgery. What are the electrolyte imbalances that can cause paralytic ileus? One is hypokalemia and other one is hypercalcemia. What are the drugs that can cause?
So how does hypercalcemia cause paralytic ileus?
Hypercalcemia, as you can remember that from the discussion of hypercalcemia, that it can causes constipation.
Okay.
Normally, calcium is required for the contraction of the smooth muscles. So if there's hypercalcemia, it means the smooth muscles of the GIT tract will contract more than it is required. There will be a spasm of the GIT muscles, which will lead to non-functioning bowel. Is it clear?
Yes, thank you.
Anticholinergic and opioids are the drugs such as morphine. They can also lead to paralytic ileus, trauma, peritonitis, and one important factor is immobilization. So after surgery, a patient can develop paralytic ileus because one, he is immobilized after surgery, and the other one is if he underwent an abdominal surgery, then during gut handling during abdominal surgery can also lead to paralytic ileus. Even if it's not an abdominal operation, for example, hip replacement. See, if after hip replacement, a patient develops abdominal distension and vomiting and absent bowel sounds, then it can also be a case of paralytic ileus, because after hip surgery, the patient is immobilized for a very long time. So immobilization is also an important risk factor for paralytic ileus. What will be the features of paralytic ileus? Abdominal distension, constipation, This one is important. Absent bowel sounds. Why this is important? Because abdominal distension and constipation and vomiting. Abdominal distension, constipation, and vomiting. These are also a feature of intestinal obstruction. How you are going to differentiate between intestinal obstruction and paralytic ileus? In paralytic ileus, on examination, the bowel sounds will be absent because the gut is paralyzed. There is no gut movement. While in case of intestinal obstruction, the bowel sounds will be exaggerated because proximal to the obstruction, there will be peristalsis and they will be exaggerated. So, if a patient present to you with abdominal distension, constipation, and vomiting with absent bowel sounds, then it is paralytic ileus, and same symptoms and exaggerated bowel sound, then it is mechanical intestinal obstruction and not functional intestinal obstruction or simply intestinal obstruction. It is important to differentiate between these two conditions because the management of both of them is different. Initial investigation in both cases will be abdominal X-ray, which will
Can you
show.
repeat that, please? The difference, can you repeat, please?
There's only one difference, and you need to focus on that difference only. That is absent bowel sounds in paralytic ileus and exaggerated bowel sounds in intestinal obstruction. Is that right?
Yeah, that's fine. Thank you.
The next step in both cases will be abdominal X-ray, erect abdominal X-ray. On erect abdominal X-ray, in both cases, there will be dilated gut loops and multiple air fluid levels. In mechanical obstruction, there will be noisy bowel sounds. The initial step is same in both cases. Initial investigation, that is erect abdominal X-ray. The management of both of them is different. In case of paralytic ileus, it is managed conservatively by NG tube and IV fluids. Inserting the NG tube will deflate the gases and suck the fluid to relieve the distension, nausea, and vomiting. While in case of intestinal obstruction, the patient need to be referred to a surgical emergency, and they will decide either the patient will be managed conservatively or or he or she need a surgery. You can see on this X-ray that the dilated gut loops now a 65-year-old woman with firm, round, painless lump in the breast. So the age of the patient is 65 years. And she has a painless lump in the breast with bruises. Bruises or with a history of trauma, most likely fat necrosis. While a lump in the breast in an old female with lymphadenopathy or axillary lymph nodes and weight loss or bleeding per nipple, then it is most likely CA breast. We have discussed this topic in the previous lecture. Itching with greenish discharge from nipple is the ectasia. Now, can someone read the scenario written in the key 49? Anyone?
Intermittent burning or stabbing pain in one part of one breast that may radiate to the axilla, no palpable masses or lumps, and no enlarged lymph nodes.
What is the diagnosis?
Mastitis.
Mastitis. What are the points in favor of mastitis?
What about mastalgia?
Burning or
Non-cyclical nostalgia.
Because it's a pain only, so it is favoring more mastalgia.
And it
It could
also
have been
says
mastitis.
intermittent.
Yes, it could have been mastitis if in the scenario it was mentioned that there is redness on the breast or in an area around the breast or nipple. Then we could have thought about. And one more thing, the risk factor for mastitis is that there will be history of smoking, and also there will be history of antibiotic use, which improved the condition slightly. So because it's only pain, a burning or stabbing pain that radiates toward the axilla, no masses, lumps, and low large lymph nodes, so it looks like non-cyclical mastalgia. The same scenario, and if there was association of with the menstrual cycle, then it would have been cyclical mastalgia. So intermittent burning or stabbing pain, let's change the scenario in one part of one breast that may radiate to axilla. Plus, if there's mention of lumps or nodularity and association with menstrual cycle, then it would have been fibroadenosis. Yes. So yes, it's non-cyclical mastalgia. If there is a lump, then same patient of non-cyclical mastalgia means no association of pain with menstrual cycle, plus there is a lump in the breast, then it would have been breast cyst. So a new piece of information is that burning or stabbing pain or pain in breast plus a lump in breast, no association with menstrual cycle, then it is breast cyst. Pain in breast and lumpiness that appears before menstruation and disappear after menstruation, then it is fibroadenosis. Everyone got it?
Could you please repeat the point about fibroadenosis, please?
Simple. The point in favor of fibroadenosis is that fibroadenosis has an association with menstrual cycle. In fibroadenosis, the lump appear before the menstrual cycle and disappear after the menstrual cycle.
And it's just a lump, nothing else with the pain,
Lump
right?
and pain, yes. Lump and pain with the breast that is associated with menstrual cycle.
Okay.
So
Thank
will
you.
it not be will it
Yes.
not be cyclical mastalgia then? Or
For
fibroadenosis?
cyclical mastalgia, there should be no lump in the breast, only
Okay.
pain,
Only
because
pain.
it's mastalgia.
Yeah. Okay.
So only pain that is associated with menstrual cycle is cyclical mastalgia. Only pain that is not associated with menstrual cycle, non-cyclical mastalgia. Pain plus lump that is associated with menstrual cycle is fibroadenosis. Pain plus lump that is not associated with menstrual cycle, breast cyst. I hope it's clear to everyone now. So post-abdominal operation, abdominal discomfort is logical as long as there is no fever or no other sign and symptoms. Only abdominal discomfort because of surgical incisions and because of operation, it can be expected, the abdominal discomfort. Even if WBC and CRP are high, then still it's a normal thing. You need to repeat the WBC and CRP after 24 hours, as long as there is no fever. So if a patient after abdominal operation present to you with abdominal discomfort, his WBC and CRP are high, but he has no fever and no other sign and symptoms, then you need to reassure him and repeat his WBC and CRP after 24 hours. Remember that during colon and rectum operations, as they contain fecal matters, there is high risk of serious infection during these operations. So usually we need to give a prophylactic antibiotic before these operations. What is the prophylactic antibiotic that you need to give in case of abdominal operation? One is cefuroxime. Because the gut can contain gram-positive organisms and gram-negative organisms plus anaerobic bacteria as well. So you need to give two antibiotics, cefuroxime and metronidazole. Cefuroxime will cover gram-positive and gram-negative both, and metronidazole will cover anaerobic bacteria. When you should give the prophylactic antibiotic 30 minutes before the first incision or at the time of induction of anesthesia. So prophylactic antibiotics that need to be given are cefuroxime and metronidazole, and the timing should be at the induction of anesthesia or 30 minutes before the first incision. So can anyone tell me the diagnosis of the scenario written in the key 52, hepatomegaly, palpable liver, weight loss, history of cirrhosis, tiredness, right upper quadrant pain?
So
CA
hepatocellular
liver?
carcinoma.
Yes, it's a CA liver or hepatocellular carcinoma because history of cirrhosis and all other things are also favoring. Now, what is the diagnosis in key number 53? Anyone? What is the diagnosis in key number 53?
Analepsis?
Yes, that's right. Excellent. Perianal abscess. What is the treatment for perianal abscess?
Incision and drainage with antibiotics.
Yes, that's right. Perianal abscess and incision and drainage. In perianal hematoma, only analgesics will be given and not incision and drainage, or no antibiotics required in perianal hematoma.
Question: how would someone get a perianal hematoma?
Perianal hematoma can be caused by any trauma. This is the only way someone can get a perianal hematoma. In perianal
Okay.
hematoma, there will be a arithmetic swelling, and the pain will be mild. And like in perianal abscess, the pain is throbbing and the swelling is tender. While in perianal hematoma, the swelling will be non-tender. Plus minus, there can be fever in perianal abscess, while in perianal hematoma, there will be no fever. So in a patient who has just thyroid surgery and developed shortness of breath and stridor, it is most likely due to a hematoma which is compressing the trachea and leading to stridor and shortness of breath. The first step is to do the cut the subcutaneous sutures. And even if after cutting the subcutaneous sutures, the patient's shortness of breath or stridor does not improve, then you need to perform or intubate him. So cutting the sutures would relieve the pressure and improve breathing. And if there's no improvement in breathing, then you need to consider intubation. Again, prophylactic antibiotics. Now, important topic for surgery is appendicitis. How you're going to diagnose appendicitis? A pain that usually start in the periumbilical area or around the umbilicus and then is shifted to right iliac fossa. This is called McBurney's sign. The pain usually start in the periumbilical area because periumbilical area or the central abdomen and right iliac fossa both have a common dermatome. So that's why the pain in appendicitis usually start in the around the umbilicus or central abdomen and then it is shifted to right iliac fossa. There can be vomiting and loose stool. There will be tenderness, rebound tenderness in the right iliac fossa, fever, and WBC and CRP will be high. And there will also be a positive Rovsing sign. What is a positive Rovsing sign? If you apply pressure in the left iliac fossa, the patient will feel pain in the right iliac fossa. Why the patient will feel pain in the right iliac fossa if you apply pressure in the left iliac fossa? Because if you apply pressure in the left iliac fossa, there will be backflow of gases through descending colon, transverse colon, ascending colon, and cecum. And cecum is inflamed. At ileocecal junction, there is usually appendix which is inflamed, and in the right iliac fossa. So that's why